Hi, Cam followers. I hope you're all well. I'm Nikki, and this evening I'm really excited. We've got the lovely Jacques Ferreira with us. He is a specialist in veterinary anaesthesia and analgesia, and he heads up the chronic pain clinics at Willows Referral Service in Solihull. So this evening he is very happy to talk to us about chronic pain and about the pain clinics that they do there, something that we're all familiar with our arthritic dogs, whether we're treating them or owning them. So I'm going to hand over to Jacques to introduce himself and to tell us a little bit about what he does, and that he has a presentation to share with us. And after that, we'll have more of a chat. So if you have any questions, please do pop them down in the comments and we will get to them at some point this evening. So Jacques, thank you so much for coming on. Would you like to tell us a bit about yourself, please?
Thanks, Nikki. Let me get more than the screen in the middle, but there we go. So yes, quite rightly, I'm Jacques, and I work at Willows in Solihull, and we run the pain clinic. My speciality is essentially anaesthesia, but part of our training is always to do with analgesia and pain management, and it's been something I've been interested in for many years, and so it was a great opportunity to establish one at Willows because we haven't had one before. So a bit of my background and where I come from. So as you can tell from the accent, I'm probably not a local. I grew up in South Africa and schooled there, went to university and went to vet school there. I got married and then ended up that my wife was invited to study at the University of Liverpool. So we moved overseas in 2016 here to the UK. We swapped flip-flops for big boots, and we got used to buying raincoats and lots of umbrellas. But it's been great. And so we spent 3 years on the Wirral. I had a great time there, and I lectured at the university got a lot of good experience, and acquired my European specialist status at the same time. And then in 2018, I moved across to Willows and have been there ever since. In terms of the chronic pain clinic, it was interesting when we moved across to Willows. As you know, we have quite a few specialities there. There's about 11 different specialities and about 40 specialists. Mm-hmm. And so with all these very clever people in one building, it became quite obvious that we were lacking in our holistic approach and multidisciplinary approach to pain management. And as it so happens, being an anaesthetist, you get to see a lot of these patients prior to procedures, both surgery and not. And then we started to see that there's quite a few patients that were, dare I say, slipping through the net and could be managed in a better, more efficient manner. And so we sat down about a year in and said, what can we do about this? And we established the clinic from there. So currently, I run it myself alongside a veterinary physiotherapist, Emma Box, who hopefully is listening this evening. And we really tried to develop a multidisciplinary approach where we took the best of veterinary physiotherapy and hopefully a bit of the pain knowledge and put it together to try and provide a full scope of practice and treatments. And we currently are practicing on an outpatient basis twice a week because obviously we still have other duties to perform. So Wednesdays and Thursday afternoons we have run our pain clinic. And we do about 100 to 120 consults a year, which is not bad considering we've had lockdown and we only have an afternoon every so often to do it. So it's grown massively, and it's just a testament to so many people being aware that there's a lot more they can do for their pets with arthritis. So so it's great to be on the show. I was really chuffed to be invited by Cam. It is well known amongst our clients, and they support it highly. So it's great to be here.
Excellent. I think you're right. Definitely, I've noticed this as well as the first opinion vet. People want to do more for their dogs, and actually, a couple of years ago, chronic pain clinics or that kind of referral wasn't an option. It wasn't really heard about, and I think still a lot of first opinion vets are totally unaware that these referrals do exist and that we can use them, and often, especially clients that are following Cam now know about them. I know for sure that vets are being asked about them, so it's great that they're popping up in some of these referral centres, and it's just it's as important as other conditions, isn't it? Really, it's a big
if you consider the cohort of the number of patients that probably have arthritis at any one time, just taking dogs into account, we have a huge amount that dogs essentially healthy and otherwise happy dogs going into old age, where the mobility and arthritis is causing such a deterioration in the quality of life. It's a shame that that becomes the forefront of what we need to manage to get them to enjoy their geriatric years. It shouldn't have to be that way. And I think it just shows where we need to go to try and better manage these patients. And this is just the first start to trying to do that, I think, is getting more exposure out to the fact that we do have these specialist clinics. There are a lot of vets who do a lot of very good work. And I have to say, I've had a few referrals where I myself is stumped and the vet has done everything perfectly. But if nothing else, we can collaborate together and say, actually, you have done everything as I would have done it. And then maybe we need to look and think out the box. So it can be collaborative as much as a referral and then pass on to specialists.
Yeah. So do you have a lot of referrals from mostly vets, or can you get referrals from your physiotherapist that people might go to see, or their hydrotherapist? Is it always from first opinion vets that you get the referrals?
Currently, the referral route is taken two forms. The one, which is our most common form, has come through another speciality service, not necessarily to treat arthritis. Our internal medicine department sees a lot of cases where dogs come in for let's say an IBS or an IBD workup due to stomach issues, and they will make a note that they felt that the dog, in addition to the IBS, is suffering from arthritis, and would we have a look? And so we get that referral route, which has actually proved very rewarding. It took a bit of convincing. Everyone believes they do well until you have the opportunity to show what you can do. But we've developed a very good rapport with all of our sections. Even orthopedics now is flying the flag for the chronic pain clinic, which is great. So that's probably the way we established it initially. About 20% of our caseload comes from external referral, mainly from primary care practitioners. And the reason why it goes this route, and the reason why I think it's a very good way to do this, is to spend our resources most efficiently, because we have a very short period where we can consult. It's important that we have a definitive diagnosis. So while we'd love to have every referral from a physiotherapist and from a hydrotherapist, we need to have the diagnosis to know what is the most appropriate treatment. So going the primary care route, it allows us to have that definitive picture, so that we can work a holistic plan around that. Yeah,
that makes sense. And so one of the questions that I was going to ask you is, what was your definition of chronic pain? And I don't know if this leads nicely into your presentation, but how would you describe chronic pain?
I think, unfortunately, and I was thinking about this earlier today, so chronic pain and acute pain are the two forms that we generally talk about in the veterinary world. And by looking purely at the definition of the terms, you would think it's to do with chronicity, to do with the time. So a dog that's been in pain for 1 day versus 30 days. When do you decide when that dog is now just ticked the box of becoming a chronic pain dog? And the problem is that definition is not really sufficient. So there's another definition that's been touted called maladaptive pain, and I think it's probably a better descriptor of what we see. So we'll discuss a little bit about acute pain and chronic pain in this talk that I'm going to share with you shortly. But I would say chronic pain is where the clinical presentation that the dog that you see in the clinic, or that the owner describes in the history, is not reflective of the current level of injury to the joints that there is. So the best way to explain it is, if this dog has a sore hip, why does it resent me touching his back? It's not a good descriptor of what should be painful and what should not be painful. So non-painful touch. So in this talk we'll hopefully be able to give a bit more of an explanation on why that's the case, and to just reassure owners as to what they're seeing, because very often the historical picture that an owner presents when at first consult with us is not one of a mobility issue. It's more of a change in demeanor and quality of life issue. And there's a very good reason for that. It's not all in the owner's head. They are actually the best forms of descriptors, because they know their animals so well. Yes. So we can go into the talk if you like, and we can crack on.
I was going to talk. Yeah, well, let's do this talk first. What I'm going to do is add you just there. Oh, I love it when it does that.
Will I try and find my
Yeah,
presentation?
you try and find it, and then I'll let you know when it pops up.
Okay, it should be somewhere here.
There we go. Yeah.
Excellent.
Hopefully everyone can see that.
Okay, so I can't see the comments. So if it's okay with everyone listening, we'll go through the presentation and then maybe we can chat afterwards, and we'll go through the comments and make sure that we cover everything from there.
Yeah, that's fine. That's great. Thank you.
Perfect. Okay. So as we were saying shortly before starting, we're talking a little bit about how do we describe what chronic pain is. And before we get to that point, I'm going to show you a list of observations, and I want to know, well, I don't want to know now, but consider if you've ever seen this in your animal that suffers from arthritis. So these are some of the descriptors that I've had from owners that have come into the clinic, and one of the most common ones that an owner will describe is that there's a recurring cycle of good and bad days. One day, my dog is perfect, and the next day, my dog doesn't want to get out of bed. And it just seems to cycle in and out and in and out, and it's such a frustration, and it really creates a lot of uneasiness because you can't predict what's going to be a good and what's going to be a bad day.
No.
A very common observation as well is a change in interaction with other dogs. So avoiding interaction is the most common. So a dog that was normally very well socialized suddenly has a behavioral issue. So we can't not entirely sure why, but this dog's suddenly aggressive towards younger dogs. And maybe male or female, it doesn't matter. But they resent the interaction, particularly when they're boisterous. Another common observation will be that a dog is suddenly having accidents in the house, but is well trained. There may even be a doggy door to get through the kitchen door, but yet still the dog messes in the house. Why is that the case?
Yeah.
A very sad one, but a common observation is one where your dog no longer enjoys being stroked. So it resents it, and we had a case in the clinic just the other day where when a dog was stroked, it would actually try and nip the owner. It's a terrible way to interact with your beloved best friend. And then a change
for some people as well, isn't it?
Yeah, it is. And I mean, I love my dog, and I would be so mortified if he didn't enjoy being stroked.
Yeah.
And then a change in behavior or interaction again will be new fears or new anxieties that your dog is describing. A classic would be a dog that was normally didn't care where it was in the house, avoiding any slippery floor, or doesn't have confidence going up or down the stairs. That's a common descriptor that we hear of in the clinic. And then even loud noises, or just the fear of the unknown. And a loud noise is the unknown, because what has made that noise? So with the exception of the stairs and the slippery floors, none of these descriptors have very much to do with arthritis in the traditional sense, because arthritis means you've got an inflamed joint, or an in-joint capsule, or in cartilage is inflamed, the synovium. And so that should ring bells that this is not an acute pain problem, because your patient or your dog is presenting for signs not consistent with what's going on.
Yeah.
And you need to start, why is this the case? And hopefully we can go into the reason why. So you asked me about what is my definition of chronic pain.
Yeah.
But probably we should take a step back and what is pain? So if we start at the very beginning. Well, pain is actually vital to supporting life. And there was an article in the BBC News a few years ago where this woman who went through life and didn't realize that it was abnormal not to feel pain. She just she would not know that she's burning herself until she smelled, it sounds awful, but she smelled the fact that her fingers were on fire. And so it's not intuitive. We all do. If I say to you, what is pain? You have a very good idea of what that is because you can perceive it yourself. And the reason you perceive it yourself is because if you don't have pain there, you cannot protect yourself from damage or injury. And so in the traditional sense, pain is not a bad thing. It will help limit further injury. It has to be there to promote repair. If you've injured yourself, you've hurt your leg. The classic was your brother's kicked you in the shin. It's a heck of a painful. You're not going to let him do it again because it's so sore. But also, you're going to look after that leg until it's healed. So you're promoting repair. And these are all very good, beneficial reasons to have a pain pathway or pain system to sense pain. And of course, it'll allow learning adaptation. So if your brother wants to kick your shin the next time, you move it out the way and you kick his. So you've adapted to the environment. Without that pain stimulus, you wouldn't be able to do that. And so actually, it's very important. So we have to then decide what is a pain stimulus. So it's an odd way to describe it, but pain should be relevant and relative. So a light touch, you lightly touch with a feather on your skin should not be painful. And we all feel that's rather intuitive. I don't have to explain that to you. You understand. That's because your pain pathway works properly. You don't expect it to be painful after it's healed, so the pain should only last for as long as there is injury. So great, that makes sense. And the level of pain that you feel should be proportional to how bad the injury is. There's no point in you having a cut on your finger and you're writhing in pain like it's the worst pain known to man. That's disproportional. That's not very beneficial to anyone. You wouldn't be able to enact your normal duties in daily life because you would be so wary of having the worst pain known to man or woman.
Yeah.
And then, of course, after recovery, you shouldn't have to deal with any residual pain. So what happens in chronic pain like arthritis? With that light touch, it should be something that's considered a reassuring touch. Suddenly is no longer reassuring, it's painful. Why is it that a patient that has a sore hip still has a sore elbow, but their elbow healed months ago from when it was bumped? So the pain lasts longer than before. That's chronic pain state. That's abnormal. It's maladaptive. And again, this is a very classic. The level of pain is not proportional to the injury. You very often hear about some dogs will go and present to a referral center for a workup for a slip disc, but actually the level of pain in their hips is so bad they no longer want to use their hind limbs, to the point that when you do a stress test to see if they have a pain response, they don't even respond because they have such a disrupted pain sensing pathway that they can no longer work out what's a normal pain and what's an abnormal pain state. These are all very chronic pain like observations. So how does this end up going like this? So what has happened? To explain exactly how this has happened, I've drawn a very dodgy looking dog with nothing but a single line to denote a nerve, a fluffy looking gray spinal cord, and then all the way up here in the red is the brain. And this, in a very basic manner, is how you perceive pain and how your dog perceives pain. So it started at the very beginning. The green bit, let's, for example, say your dog has a tarsal arthritis. So it's the hock is over here is painful. So this is all inflamed and sore. But how does your doggy, whose brain's over there, knows that this part of his limb is sore? You've got to first, or the pain pathway's got to first establish that there is damage. It's got to create a packet of data that's proportional to the level of damage there is, but it's also got to get this data from the foot to the brain. And it does this by following a very strict nerve pathway. So we call this a primary afferent for the vets and a secondary afferent. And for the owners out there, this is just a big nerve that runs from the tip all the way up to the spinal cord. And so that packet of data that tells you that you've hurt your foot or has a sore arthritic joint is going to move through this nerve all the way up towards the spinal cord. Now, at this point, the spinal cord acts as a little bit like a judge. It's got to decide every single stimulus and packet of data that arrives from all over the body, which one is painful and which one is not. And it's going to then allow those painful signals to go all the way up to the brain to tell you that it's painful. And those non-painful signals must go elsewhere to be interpreted as such. So that could be proprioceptive, telling you where you are spatially or where your joint and how is it moving and what else. And those are all non-painful stimuli. But the most important thing that this pain perception and this pain pathway does is make sure that everything is in equal balance. So, for example, let's go back to that paw. Let's say you cut the paw. Your dog went and ran outside, cut the paw, and now it's painful. The level of pain that your dog feels should be equal and balanced to the level of injury that this has entailed. So how the heck does this nervous system do this? How does it be able to work out exactly what's an appropriate amount of pain and what's not appropriate? And it's a little bit like passengers arriving at an airport. So bear with me. This is my airport analogy. So let's go. First things first. Painful stimulus is in green. We said that there's a cut paw. That is like having airplanes of painful stimulus arriving at the nerve. So in these airplanes are a whole bunch of signals, which are you, the passenger. And you, the passenger, have just arrived from somewhere, but you are essentially in a pain signal. And you have to get all the way to the brain to be interpreted. But you have to go through a series of processes to make sure you are who you say you are. And it's the same as going through a passport gate. Okay, so there's this restricted access, and this is at the spinal cord level. Okay. And you have to verify that your painful stimulus is what it should be so that you can go through the passport gate and go to arrivals, which is the brain. Nice. And then you will interpret it as pain. So, as we said, it carries all kinds of packets of data, and there's going to be painful and non-painful stimulus that will run through these nerves. And it's up to the spinal cord to decide. And we spoke a little bit about where passengers and signals will go all over the place. So you may be here, but you need to get to there to catch a connecting flight. You may be a painful signal, you may not, but you've got to go somewhere and you've got to be regulated by the spinal cord. So, spinal cord is integral to establishing a chronic pain state. When the spinal cord is doing its job properly, when its passport gate is working correctly, it can quite easily separate the painful from the non-painful signals. And this is integral to a normal you and I. So we can go around and confidently know what is painful and what isn't. But, and just like with, so when you verify who you are, you have to do a biometrics check, which is essentially looking at your passport, and the picture should be you and the fingerprint should be you. And it's just like this with pain. For a pain signal to go through to the spinal cord, to go through the spinal cord modulation and to go to the brain, it needs to be ticked off as being a properly painful signal. And all being well, you end up going there. But when you go to a chronic pain state, it's essentially like having too many signals or too many people arriving at the airport at the same time. And whatever essentially happens at the sorting gate, at the passport gate, there is an overwhelming of the system, and it no longer can be 100% predictive of UK passengers who, like, let's say, for example, UK passengers are your painful stimuli, and they're going to go to the UK passport one. And non-painful signal or non-painful stimuli are going to go to all the other passport. When there's a derangement in the spinal cord, you can no longer differentiate between these two cues, and there's a muddling up, and there's a disproportionate number of UK arrivals. So if you were counting them, for example, who goes through, you wouldn't be accurate anymore. And so this is the same with the chronic pain state. Too many signals, too many passengers arriving at the passport control too quickly. You overwhelm the passport gate. And when you overwhelm the passport gate, there's two options to passport control. They either back it all up and wait and wait and wait, or eventually it gets overwhelmed and it flows into the other passport queue. So now you've got UK passport holders or pain signals going through non-painful pathways. And now this is the first upcycle. This is the first type of chronic pain state that we get, and we call this peripheral sensitization. Too much stimulus is arriving at the spinal cord. When this carries on for an indefinite period of time, the spinal cord will eventually be overwhelmed, and everything will be allowed to go through the spine, through the passport gates, and everyone can just arrive at the arrivals lounge. And now every signal, painful or non-painful, you could be a signal saying that there's a joint movement, but because you've overwhelmed these modulatory control in the spinal cord, the e-passport gate, every single one of them, it gets perceived as painful. You have now essentially lost your ability to differentiate, and now you've developed a chronic pain state.
Right.
And it's at this point you start losing the ability to differentiate what's painful and non-painful. Because, yes, you would have counted the UK passport holders, which were your actual painful stimulus from the arthritis, for example, in that allotment of people, but you've also counted joint movement, stimulus of hair, light touch as being painful because you've lost the ability to differentiate. And now the state of pain exceeds, it's no longer balanced to the level of injury, and now you've induced chronic pain. And what
That's
happens when you...
such a good thing. I'm going to use this every day of my life now, I think, this airport thing. Thank you. Carry on.
Yeah, it is ironic considering no one can fly at the moment, but at least we can use airports for something.
We can dream.
Exactly. So, so when this happens, when you lose this ability to differentiate passengers from other passengers and pain from non-pain, you're constantly sore. It doesn't actually matter what you do, what your dog does. It can lie down, it can sit, it can fall asleep. Your dog may go for a walk. Your dog may go down the stairs. All of that will be stimulating signals or passengers to go to those gates. But because this differentiation is lost, it's just going to be interpreted as pain. And it will lead to a level of depression in dogs. And interestingly, this is something that we see in humans. So if you go look at human chronic pain clinics, it's not uncommon to see a chronic pain practitioner work along a psychologist or a psychiatrist. And that's because the emotive component of pain is so interconnected with the actual underlying pathophysiology of pain that it's almost impossible to differentiate. And so you need to almost work at both at the same time. And that's why we see so many behavioral changes in our animals. And that's why when your dog is suffering from chronic pain, it seems to be very little to do with the joints and very much to do with the quality of life. And eventually these depressed dogs will become withdrawn. They just won't be interested in going for their walks anymore. They won't be interested in interacting with you. They won't be interested in playing with their favorite toy, or they don't want to interact with a fellow dog housemate that they used to be best of friends with.
Yeah.
And so when we go back and look at these observations again, it suddenly makes sense why you have good and bad days. Because depending on the amount of stimulus arriving at your spinal cord or your dog's spinal cord or the passport gate, you may find that you overwhelm those systems more on one day than the other. And so you'll have a dog that'll be happier on one day versus the other, because it's all about how much stimulation there is. And again, if they've lost the ability to differentiate painful from non-painful and everything is painful, then an interaction with another dog is painful. Same with going and toileting, because the mere act of having to squat down to toilet for some dogs is so horrible because it's so painful, even more so than just having a sore joint, that they're not interested, and they'll hold and they'll hold and they'll hold until they can't, they're bursting, and then there'll be an accident in the house.
Yeah.
And likewise, we were talking about light touch again. Another reason why light touch would be so painful for a dog, because the signals, what's sore and what's not sore, are completely mixed up and muddled, and what arrives to the brain is just an over bombardment of pain. And so if you don't know what's painful and you don't know what's not painful anymore, anything new is suspicious. So that could be a new floor, it could be a new sound, so fear, anxiety to a noise that never was before. The car that arrives at home is suddenly anxious because your doggy wants to come greet you at the door, but it's got to go to the slippery floor to get there. That's suddenly become an anxious event, which used to be a lovely event for you and the dog. And so it's all tied up into this, and none of this is, again, to do with the arthritis, even though that was what started this in the first place. We can talk a little bit about why arthritis does this, if you like, but essentially when it comes to chronic pain, that's how it happens. But there is some good news. It's not all bad news. We can reverse these systems with the drug regimens that we use today, with the multiple pharmacologies that we have, with the complementary therapies such as hydrotherapy, acupuncture. What we have at our disposal is the opportunity to go and fix those broken passport gates, to slow down the number of passengers arriving at the terminals, and to allow the normal perceived nature of pain to reoccur. So everything functions normally, because a dog doesn't need to know that it's painful when it overdoes it, if it's got bad hips, but you just don't want him to be painful and not enjoying life. And with chronic pain clinics that we have today, we can start developing that balance and finding a way to manage it so that your doggies go back to normal.
Yeah.
So that's the short form of chronic pain, and I appreciate that is it's not complete. We could talk about drugs, we could talk about all sorts of more complicated pathways, but the take-home message is essentially that the differentiation between what is painful and not painful is lost. So thanks.
Yeah, thank you. I'm going to take that off and get our faces back on there.
Okay.
There we go. We're back. Yeah, people have loved that analogy, loving the whole airport thing. As I say, so do I. It makes it really clear, doesn't it? I think it's a really good way of thinking about it. So with the arthritic dogs, and just to go back, because we were talking about with that, you're getting a pain in the foot, and then it's sending those signals for the pain. So in arthritis, do you feel that this is happening then because it's been there for so long, and then, like you say, that it's often not like a lameness that they present with. It's all these subtle signs that you may not initially think, well, that's because of arthritis, and then you kind of have to exclude other conditions, I would imagine, and then or start looking for x-rays and that kind of thing to get a diagnosis. So with the arthritis, how would that build up? How would you see it starting and developing to chronic pain? Because it wouldn't initially cause chronic pain.
No. So I think it's important to appreciate that arthritis can develop from a number of different ways, and we see it in different types of dogs occur at different times in their stages of their lives. So the classic example is a 1-year-old Labrador with bad elbows. They don't necessarily have arthritis, but they've got a predisposition for cartilage breakdown, OCD lesions, for example. And so that is telling them they're painful and they're not supposed to move their limb, and that's good. That's protective. That doesn't necessarily mean that in 5 years' time that they're going to present with an elbow issue at my clinic. They'll come and present because they're no longer themselves. And so what we have to remember with these cases is inflammation is there to try and to protect the body from further damage and to heal. And one of the ways is pain, but another way is to try and provide fibrous tissue and adhesions. And over time, if your dog has got arthritis, those adhesions will develop and they'll create a change in the way the joint moves. And that doesn't necessarily mean it's painful, but it doesn't necessarily mean your dog is now walking most efficiently or running most efficiently. And just like all of us, none of us are perfect in the way we move and the way we run. And I try to do a bit of running myself, and every now and again I'll come up with a painful knee and I'll have to slow down. And this is all because I don't have a perfect system. I'm not running perfectly for my body system. It's the same for our dogs. But there can come a stage where eventually, because they're constantly having a little bit of pain there, that's not really arthritis. It's because their muscles are sore because they're holding the joint in a different position because they can't move their joint. The muscle gets sore. And that's quite normal as well. But a muscle stiffness, everyone's had it. The DOMS, the 2-day DOMS, and that's okay. But now I've got a slightly grumbly joint. I've got muscles that are a little bit tight. And so my dog goes for a long walk with me in summer because it's a great day. And we normally do 5 kilometers, but today we're doing 10. 7 kilometers into my walk, my dog is now, his muscles around his hip, for example, let's say it's the hip that's sore, is now getting stiff. And so now he's changed the way he's moved his back. So now he's using his back muscles a little bit more than he would. He's swaying a little bit more. Nothing severe, just enough to move his back into a different position than it would ordinarily carry itself. And now there's a few little facet joints that are a bit inflamed because he's carried his weight differently. Or he's shifted his weight forward because his hips are a little bit stiff. Now we've developed, we've created a huge wind up where my dog had an arthritis, but now he's got sore muscles. He's now got a slightly dodgy back because he's had to use a little bit more to get him home. And then towards the end, he started shifting onto his front limbs to carry his weight more. Bearing in mind, dogs carry 66% of their weight on their front limbs. And now he's got sore ankles. All of this will create a lot of stimulus, and a lot of passengers are arriving at our airport, and that will start overloading the system. And that is why you get this chronic pain state. I know it's long-winded, but that's sort of the way we understand.
It builds up, and I think that's why arthritis is often, the initial stages are often missed, aren't they? Because they're very subtle. There's not a lot to see, and as an owner or a vet, you wouldn't necessarily pick up on very much.
No.
I mean, what do you feel is the most common presentation? I know, like you said at the beginning, that actually a lot of your work is in-house referral. And a lot of it is depression or just not themselves, behavioural changes. What about the ones that do get referred to you, what do you feel are the most common presenting signs?
The most common presenting signs, there will be often it depends on where they arrive, I guess, and there's always a caveat to these, but a lot of the dogs that will present to the clinic from external referrals will have a history of exercise intolerance that doesn't have an underlying cardiac or respiratory component, for example.
Okay.
And so that's one. So this dog is just not itself. And then the other would be the behavioral change where a dog has become aggressive. That's common.
Yeah.
And then the other is where a dog has had a diagnosis made. And this is why it's more challenging, I guess, because as a primary practitioner, you guys will see them a little bit sooner. You will see them when they've come in and it'll just be, oh, he's got a sudden limp that he's had. But it comes and goes, not that bad. He still does what he wants to do. But it's just grumbling on the end, or he doesn't keep up with his mate in the park to the same degree.
Yeah.
So it can be quite vague. But yeah, that's probably how we would see them arrive at the clinic. We, unfortunately, because we're in a referral center, we see them at quite a late stage as well. So at this point, the level of mobility is so reduced that we're looking at trying to get them back to doing just normal stuff again.
Right.
Whether that's going outside for a short walk around the garden, etc. So they are quite advanced.
Yeah, and most of them will already be on a combination of medication.
Yeah, and that I'd say the other big reason for referral for us will be the non-steroidal and maybe gabapentin combination. So very often it's been on anti-inflammatory, been on a nutraceutical. So UMove, for example, and very often you'll hear UMove worked really. This is the classic. UMove has worked really, really well, but now it's not working so well. Yeah, and that kind of fits in line with what the drug is designed to do. It's been designed to support cartilage growth and to maintain cartilage health. But over time, cartilage will eventually wear and become brittle. And at that point, your nutraceutical is almost irrelevant. And then the non-steroidal, that's the classic. They're no longer actually, they're not the same on their Rimadyl.
Yeah. Yeah. So it's not the fact that the drug isn't working necessarily. It's just that the condition, the disease has progressed to the point where it's unable to keep it in check, I suppose.
Yeah, and that makes sense, doesn't it? Because and there's no point in using too much polypharmacology too soon. So if the dog is doing very well on a nutraceutical, don't give it a non-steroidal unless it needs it. But it will eventually need that non-steroidal. So yeah,
save it to when it does. So just thinking about your pain clinics, tell us a little bit about how it works. So if somebody were to come to Willows for a pain assessment, a clinic, what would happen? What do you start with?
So we once there's been a request to refer, we will request from your vet or from any of or from the hydrotherapist or physiotherapist to have the notes sent over, just so we can have a clinical history and picture, just to make sure that we are up to date with what's been used before, if there's any issues with other drugs. But on arrival, essentially in our first consultation, we're quite unique in that both Emma Box, the veterinary physiotherapist, and myself, we co-consult.
Okay.
And this was sort of born out of necessity, really. So we used to consult separately, but very often had overlapping cases. So we would, which makes sense because of complementary therapies. But then lockdown happened, or shall we say COVID-19 happened, and we no longer could get our patients into the building as easily as previously. So to make it more efficient, we would co-consult. And so we would do all our stuff at the same time. So the dog would only have to arrive once a week, for example. So, but then we realized how effective it is to have two heads in the same room at the same time, thinking about the dog in two different ways. And while I'm the first to admit my clinical examination is nowhere close to Emma's. A veterinary physiotherapist's hands are unbelievable in what they can pick up. And and it was so obvious from the first time we started consulting together that this was the way to go. So what we do essentially is normal times, you'll come in with your dog. We'll probably spend a good 20 minutes getting to know you, getting your side of how it's going. What do you feel has happened to your dog, and what do you want to achieve at the clinic? Because everyone's different in what they want in terms of an outcome, and it's important to create a tailored plan accordingly. And so once we've got that picture, we'll examine the dog, and Emma will do her magic and tell me exactly every little muscle, which problems are wrong, where, how. It's like a forensic investigation.
Yeah.
And through this and the gait analysis, we build up where all the abnormalities are. Where do we think we need to focus our efforts initially, and then going forward. And then I look with that in mind. I then decide, what do I want to achieve in a 1 week's time? Because very often a dog will come in and will be, let's for example say a dog comes in with really bad hips. It needs physiotherapy, it needs acupuncture, but it's not in a pain state that can actually tolerate those therapies at that time. Yeah. So we'll take a step back and we'll say, you know what, we're going to try and achieve one small forward step here, and we'll try and control and manage that chronic pain state to bring it down just to a normal level, not abolish pain completely, but just to a level where that dog will hopefully enjoy the complementary therapies we'll do and not try and run away from them. So first consultation is establishing the clinical picture really in depth, looking at what current pain plan that dog is on. Can I make one good change effectively? What will that be? And then the other big thing that we do is we objectively pain score them. So it's a client questionnaire.
Yeah, I was going to ask about this.
Yeah. And so what we do is we actually get the client to fill it out. And there's no right or wrong answers, and it's just establishing a baseline of where we're at. And so we can then monitor our therapies objectively using the pain scoring system, as well as subjectively using our own interpretation of what we're seeing and what the client's seeing in future therapies. And then future sessions. And then we'd normally like to see the dog back within 7 days. So we don't want to spend too much time apart between the two consults, purely because it's fresh in our minds. We know exactly what we're looking at, and then we can see where we want to go to next.
Yeah.
So that's essentially how we run it from an arthritis point of view. The consult's about an hour from the initial, because it takes it's quite intensive to establish the clinical picture and the treatment plan. And then the follow-ups from that will be also an hour, but they'll be more therapy based, where we'll catch up with you, the owner. How's it going? Pain scores, etc., and then we move forward with acupunctures and physio.
So are you asking your owners to do these questionnaires on the day they come, or are they doing them at home throughout the treatment? Are they how often are you asking them to score or have a think about how their dog is doing?
So it used to be, when we first established this, we decided it was just practical for the owners to fill the form in the waiting room prior to the consult. It proved to be logistically a bit more challenging. Everyone knows that when you arrive at the vet, the dog doesn't want to get on the weigh scale. You're struggling to check in. Now someone hands you a form. You're not really thinking about what's going on. You fill it out, half fill it out. And so it became quite tedious. And then with lockdown, it wasn't possible. So what we did essentially is, I'm very fortunate. My brother's a web developer. We put our brains together and we created an app. And so now arthritic patients that come to see us, they can download an app from the App Store.
Oh, amazing.
And so it's all on the mobile device. And so they can set up when they want to have a reminder from the app. So the app will remind them once a week, which is our suggestion of whichever day and time suits them. And then they fill the form, they complete it. It sends me the score, or sends me the completed pain scoring system, uploads to a database, and then I can pick it up remotely. And we track them. We track over time, and we can see the magnitude of change. And so that has been really integral, because one of the big questions we have from owners, and it's a very good question, is, am I actually achieving anything? And it's a challenge, because owners see their dog every hour, almost, particularly in lockdown, every hour of every day. So the magnitude of change that you'll see as an owner is so small. And yet for us, we see it on a week-on-week basis. But it's objectifying that will help us make better decisions in the long run. So
Yeah.
this has been a huge step forward for us, and we're hoping it's currently piloted for just my clinic, but we are hoping to open it up to practitioners all over in the future, so that it can be used in this manner.
Yeah, there is another one, isn't there, where people you pay and you score, and owners and the practitioner has access to it. There is one there already, but I think it's an app. Oh, I can't remember.
Yeah. I know Vetmetrica is one.
Yeah, Vetmetrica. Yeah.
I think the only thing is it's quite cost prohibitive, and
Yes.
I think owners spend so much money on medication. I'm much rather spend their money on medication and therapies than on apps. So the plan is to make it hopefully as cost effective as possible in the future. So I think that has been a game changer.
But then I think, I mean, I know CAM, we sort of promote people using the CAM diaries and just tick good day, bad day, and notes. And I mean, over time, you get to see patterns, don't you? And know if it's getting, we always have that conversation: are they having more bad days than good days? And actually writing it down every day isn't a bad thing. It's a good thing.
Yeah, exactly.
You always forget. And
and I think it's the same with internal medicine. Vets often ask clients or owners with dogs that have irritable bowel syndrome, IBS, to have a diary as well. And it's just so that you can map progressions, because there are cyclic changes that you see. And what we've seen, interestingly, there was a case, and I'm unfortunately I don't have the data with me, but we had a classic example of one of our patients who is a greyhound that we managed brilliantly. Then lockdown arrived, and we couldn't see her for the first 6 weeks, and she was a weekly patient of ours.
Right.
And nothing changed from a therapeutic point of view. The drugs were the same, everything changed, everything was the same from that point of view. But she couldn't get her acupuncture and her physio for 6 weeks. And it was just phenomenal to see the pain scores just rise, and they plateaued right above where they should have been, almost to where she was when she arrived with us in terms of baseline level. Yeah, and then it was quite alarming when we saw the rise in pain scores. And so we ended up that was our motivation to get our clients back into the clinic as soon as possible, because it was becoming an ethical issue. And so we were able to eventually get those scores back down again.
God, just the little changes make such a difference, don't they?
Yeah, exactly.
I mean, I know somebody asked the question earlier on about, or commented about changes to do with weather as well. I mean, do you find over winter that they are struggling more, or do you feel that's a big thing, or not really?
I do. I can't say I can predict which dogs will be more affected by weather change. I think it's quite individualistic.
Okay.
And I think a lot of that's due to central heating. A lot of dogs that live inside in winter won't necessarily show the same level of discomfort. What we do see more of is heat-seeking attention. So some dogs the classic sign is, he just loves lying by the fire. It doesn't matter how hot the fire is. And yet other dogs will seek cold surfaces.
That is a common one. People don't understand why.
So with weather-wise, it's probably, for what we see, is more temperature-seeking change in behaviour.
I'm just going to go through a couple of these other questions here as well. I mean, there was also a comment about stairs and arthritic dogs going up and down stairs. And it's not too much to do. Well, I guess you do discuss a lot of managing chronic pain is about managing or changing their lifestyles as well, isn't it? So is that something that you discuss a lot, like the slippery floors and stairs?
I think that's a very good point. One of the, again, it's tricky, because to make a blanket statement regarding stairs is not that simple, because the question is not whether your doggy is using the stairs or not, is why is your dog using the stairs? Because very often dogs will go up the stairs to sleep in their owner's bedrooms at night, for example. And that's what, or there's quite a few dogs that will sleep on the landing, and that is a form of behavior and a form of comfort that they seek. And so what we do is when we discuss stairs with owners, we first try and establish is, do they go up and down the stairs because you moving up and down during the day and they're just following you around, or is it because at night they go up the stairs and that's where they go to bed? And if that is what makes your dog happy, then we need to find a way to assist that dog getting up the stairs.
Yeah.
But if it's the dog following you because that's what your doggy does, then you need to seriously consider if it's in his best interest. Put a baby gate up and restrict
Yeah.
access for a while and see if that makes him feel better because he's not having to do the stairs anymore.
Yeah.
Another one is, so we use it as an indicator of how a dog is doing. So we'll often hear that a dog doesn't like going up the stairs, which obviously for the joints can be quite a lot of discomfort, but it's often got to do with the confidence that they have in taking the steps down the stairs. It's more challenging for them. And when they're feeling more confident that they can distinguish pain from non-pain because they're not in a chronic pain state,
right,
they were happy to go down the stairs. And so we use that as a metric that actually your dog is doing quite well, because we know when Fluffy's happy to go up and down the stairs, he's quite happy, that's his happy place. So
it's something they feel they can tackle then.
Exactly. It's not always I guess it's a convoluted answer, but it's not always as simple as yes or no to the stairs.
Yeah, and I think you're right. To stop some dogs going up the stairs would be to actually make their quality of life even worse, which is what you're trying not to do. So I can see that. We have got a question here from Louise, which says, my 13-year-old setter has arthritis in most joints, but can no longer take non-steroidals. This is kidney issues and is recovering from bad pancreatitis. Is there anything else that could help with her pain? She has acupuncture every 3 weeks and weekly massage therapy. She has good days, but is reluctant to go on walks now, but has little plays in the garden. I think anxiety of outside the garden could be contributing after listening to what you said. So it absolutely just that anxiety.
Exactly, and I think it would be interesting to hear if there's a stone path in the garden that she hates walking on, for example, or there's steps to go down into the garden, or is it uneven? Because that will all play a role. That's a challenging case, particularly with the pancreatitis that's there. What we see, and this is often what presents to our clinic, is when the non-steroidal cannot be given anymore. What do we do? And the issue, well, we've got a few options, and there is a non-steroidal like drug that has been released not so long ago, which is probably where I would look at considering in your dog, even with the renal disease, because the likelihood of it's not the same as the normal Metacam and Previcox. And the reason is, once you've got a non-steroidal on board, you can use other drugs like amantadine and memantine very effectively in conjunction, and that will probably be something that you would find quite rewarding in that setter. So there are options to that. In the interim, what you can do is you are doing the acupuncture and the hydrotherapy and the physiotherapy, which is great, but we need to consider why your dog is not enjoying the outside as much and see if we can improve that. So environmental alteration is something you could look at. I know some owners have put ramps in to help dogs. Some doggies just refuse to go on the grass for whatever reason, and then you have to tolerate having a paved area or whatever, if whatever's possible. But changing environment can be quite useful.
And just thinking about what the biggest anxiety is about, and then trying to avoid those areas.
Yeah, and sometimes it's a process of elimination. You won't always get it right the first time, and this is why it's so important to have a good relationship with your chronic pain practitioner, because it's almost impossible to work this out by yourself. As the practitioner, I can say that as well. Without the input from you, the owner, there's very little value I can add, because you will know the dog and your environment's the best.
And I guess one thing that should always be said is that the smallest thing that you think may not be important that's changed for your dog could be the biggest clue as to what's going on.
Oh yeah. It's you almost have to be systematic, and it can be. Dare I say, you need a bit of patience to try and work out what it is, and there's, as you say, it can be the smallest thing that you would never in your life think it would contribute.
What's the weirdest thing? Do you think the weirdest symptom that you think, oh gosh, we would never think that's arthritis, and think, oh gosh, actually,
there was a dog that let me think. That was the classic is the change in driveway. People just don't consider. So someone's had a driveway paved, or they've put the stone gravel driveway down, and now suddenly the dog doesn't want to go for a walk, and everyone thinks that the dog's getting senile, but actually it just doesn't want to walk on the stones. what else have we had? We've had a few. There was one where there was just builders that were next door were I think breaking through a wall to do an alteration on the house next door, and the dog just became so anxious because it was the fear of what was going on outside and the inability to adapt if that came inside. And we worked around everything else. We talked about the house, we talked about the dogs, we talked about everything. And then we were chatting away, and in passing, as we were finishing up, she said, "Oh, I can't wait for these builders to finish next door. The noise it's just you cannot imagine." I just thought, that's it. That's exactly what it is. And we started troubleshooting and saying, well, when did the builders start? And we worked backwards and worked out that's when the behavior changed. And it was just the change in noise. Yeah.
Yeah. Just everything, isn't it? So just anyone watching, anything that you think isn't worth mentioning, it is always worth mentioning. It could
someone picking up an instrument for the first time. I don't know, trumpet player, who knows?
Yeah. Nobody likes that. Yeah. I've got a question here from Barbara about, can muscular fatigue make a dog shake, shiver from the limbs? I would say yes, it could. Is that a common thing that you see, shaking from like at the end of exercise?
I guess the yes is the question. Definitely, shaking can be something you witness at the end of exercise. The question you've got to ask yourself: is it the muscle fatigue, or is it is it a secondary to the pain as a result of them looking tired, but actually the joints or maybe not have been overused? And I would say it's probably more a secondary sign of discomfort.
Okay.
We don't often see, unless it's a very well muscled greyhound, for example, you won't necessarily see great amounts of muscle stiffness that are going to result in shivers. I would say probably look more as a pain response.
Yeah. Again, just worth noting, isn't it, when you're talking about it? Another one here. My dog has been. Wow. Okay. I'm going to let you read this one. This is Jane. My dog has been diagnosed with chronic pain syndrome, brain degeneration, and paradoxical pseudomyotonia. Would he be able to be seen? So this isn't really a specific sort of arthritis question, is it?
Yeah.
But, answer it anyway if you can. Would he be able to be seen?
Yes, of course. We don't exclusively work with arthritic patients, and so neurological candidates who've had some form of chronic neurological disease can very often have abnormal pain states. We call them neuropathic pain states. Essential lesions, lesions that will be in the brain, for example, which could cause a myotonic type lesion, can be more challenging. But what we do with those cases is we would see them via, again, the strength of Willows is that we have multidisciplinary. So we would see that in conjunction with the neurologist.
Yeah.
And yes, definitely, because together we could work out what would be the best plan going forward. That would definitely be the route to go through. You would need to be referred through neurology. And the reason being is when it comes to lesions in the brain, we need their assistance to give us a clear idea of what do we consider to be normal in your dog, and what do we and how to best achieve that is what we can work together to do.
Yeah, I mean, I think that kind of is managing expectations a little bit as well, isn't it? Like you just kind of said, and that is the same with arthritic dogs. You're never going to get a dog that is how they were. So if you've got a 15-year-old collie, that it's not going to behave as it was when it was 1 year old, and it's managing expectations all the time. Is it, like you said, you have to tailor your plan to what the owner wants to do with the dog, and have that discussion every time, I guess, as to whether you're achieving what you expected.
I think what's so interesting working in a pain clinic is we never have to question an owner's enthusiasm and commitment. When they've arrived at the pain clinic, they are already committed and enthusiastic and ready to do anything. And so you have to, at times, provide a bit of perspective as to what is achievable, what is realistic, and then what do you think is acceptable, being the owner. And sometimes expectations do have to be somewhat subdued and reduced. But once we're all on the same page, then that's when you work forward, and you're able to find a happy medium where ultimately you and your dog are enjoying each other's company and doing what you want to do.
Yeah, yeah. I've got one on here about supplements, which I know you mentioned you move, and it's always a building block, isn't it, for treatment, really? And like you said at the beginning, if you move is working, stick with it, definitely. So this question is from Bethany. Is there much point using things like you move if a dog has such chronic pain and it's already on NSAIDs? Are they unlikely to do much, or are they likely to do much alongside pain relief at this point? I mean, how do you feel about using nutraceuticals already into the journey?
I think the issue with nutraceuticals. So we in veterinary medicine we talk about evidence based. So a lot of the decisions that we make will be based on trials and clinical trials showing that the certain drug works in a certain type of patient. With nutraceuticals, there's a significant lack of enough clinical trials when used in conjunction with the likes of a non-steroidal that I unfortunately cannot say definitively that it will make a difference once you've got a dog on non-steroidals. Now, does that mean that your dog won't benefit from it? No, that may still provide some benefit, but it would be in conjunction with the non-steroidal. If you had to remove the non-steroidal, the nutraceutical will be unlikely to be sufficient by itself, but it may add some value. In a statement by the American Veterinary Medical Association on nutraceuticals, they had a very good way of approaching it. If you want to give nutraceuticals to a patient and prescribe them, you're more than welcome to. However, due to the cost of nutraceuticals, it shouldn't be preferentially selected over a non-steroidal because the cost incurred to the amount of improvement you'll get is not necessarily the same. So essentially what that means is if you want to add a nutraceutical, by all means, but if it's going to cost you a lot of money and stop you from potentially being able to put on a more effective drug, then I would be cautious and maybe reconsider.
Yeah, definitely. And there is more research, there's more work being done on nutraceuticals all the time, isn't there? And I'm sure there will be more stuff coming out and new ones to use as well. Let's just see this one. So this is from Sarah. My 13-year-old lab has arthritis, has been on Nutricrin, Rimadyl and paracetamol. He has recently been hospitalized for an infection and was only given the paracetamol. Since then, we have not restarted the Rimadyl as he does not seem to need it, but is still having the paracetamol and Nutricrin. Does this sound okay? What do you think?
Yeah, that's a good question. And I guess did it say how long ago you stopped the non-steroidal?
No. Just as recently.
Okay.
So I'm imagining in the last few weeks.
Yeah. So I guess the question is the question is, if it's been as recent as 5 to 7 days, there is still a chance that there's still some non-steroidal left in the body having an effect. And we do see this sometimes where we'll have to swap a dog over from one to the other, and we have what we call a washout period where they won't have any non-steroidal. And the next day after stopping Rimadyl, for example, the dog is fine. 4, 5, 6, 7 days later, they seem to be showing a little bit more pain, but because you've got the paracetamol on board, it's covering that pain. Now, if it's been longer than 7 days and the non-steroidal hasn't shown a lot of benefit and your dog is still being able to do everything the same, then I would say that there is a chance that the non-steroidal that has been on for some period of time is no longer as effective as it used to be. And this is something we do see with the chronic use of one non-steroidal for over a period. And so by all means, if you have to give less drug and your dog is just the same and happy, go for it. That's first prize. But always be cognizant that if your dog does relapse, you can go back to Rimadyl, or you can preferentially try another non-steroidal, because we can't definitively say that Rimadyl is better than another non-steroidal. Every dog is different on which one is going to work the best.
And I think in those situations, I would be starting to look for those really tiny changes again, because they're the ones that are going to say, actually, he was doing better when he was on the Rimadyl. Is he now a bit slower? Is he not as keen to go on the slippery floors? And just those tiny things. And
restlessness at night is another one. Dogs that don't sleep through the night.
Yeah.
That's the first sign we often see of a drug that's no longer working, or when they need to have a change in dose. And this might be the same in this case.
Yeah. Worth just keeping a really close eye on that anyway. I've got a message here from Sharon. My dog has become incontinent due to pain. Due to pain, it breaks my heart. He doesn't know he's going. His tail goes up and it falls out. I don't know too much, Sharon, about what your dog is on, or how far down this arthritis journey he is. But definitely chat to your vet and see if there's more that can be done, because there often is, and it's not always to do with drugs. There's other things that you might want to try. Would you agree with that, Jack?
Yeah, I guess this is the really sad part about arthritis. We've spent a long time talking about chronic pain, and in humans, for example, if you had a bad hip, they would replace it with a better one. And that's not always possible in our patients, particularly with elbows and non hip based prostheses. And so you inevitably reach a point where your doggy has still got all that life and happiness in them, and you can see it, and they're willing to go on. They just don't have the musculoskeletal system to provide that means to do that. I would, again, it's difficult to say what to do where you are in that journey, and who are you working with and you trust. If you are concerned, you need to sit down and have a real discussion, and it's something that you're entitled to do. You're entitled to say, well, I'm really concerned of quality of life. What you, as my vet, what do you consider to be absolute bare minimum quality of life indicators? And if that's, for example, some people incontinence would be that, so other people that's not even close to them. So it's an individual discussion you should have. Definitely have a word with your vet.
Just have a couple more of these, so I'm quite aware we're running over time as well. This is Nicola. We were diagnosed with onset of arthritis a year ago and dementia. I feel most of the symptoms are chronic pain, but chronic pain and dementia, there's a lot of crossover, I think, isn't there? Would a hip sling help? He's cold attracted, steps are an issue, doesn't like to be touched, won't wag his tail, stares at the cupboards for ages, paces a lot, drips wee all the time, and poos without knowledge. He's on U Move at the moment. I don't know if that means he's only on U Move, but if he is, again, have a word with your vet. I think the question was about the hip sling. Yeah,
so I guess if you had to stop the question and said, would a hip sling help, we could go into a big discussion. But then the next sentence, I think, can it pop up again? Is that possible?
Yeah, sure, sorry.
Yeah, he said he's cold attracted and his steps are an issue, fine. He doesn't like to be touched, I think is that. That's a real big indicator that you've got a chronic pain state. Now, if you don't like being touched, you're really not going to like being manipulated with a sling. All of these signs that your doggy is demonstrating is more to do with the global pain problem than a specific hip joint, for example, that's going to be improved with the sling. So I would, again, doggy dementia is not it's a diagnosis, not an endpoint. You need to discuss with your vet whether you think that chronic pain has been treated sufficiently to make an educated decision on how much of an effect on quality of life the doggy dementia is having. But I don't think the answer will be as simple as a sling, for example.
No, that's a good point. I mean, I think you said this at the beginning as well. Things like acupuncture and physio are great, but it's not always a starting thing to do. You've got to manage a degree of pain before you can move on to that kind of therapy.
Exactly. And sensitivity to light touch is a really big warning sign that it's probably not controlled adequately.
I'll just do one more, and then we'll do this one. So not sure if this is a place to ask, but when would you start a dog on non-steroidals after joint supplements, and when would you refer a dog for other therapies such as hydro, acupuncture, physio, right from the start? Right from the start, when the owners first present the dog for stiffness and being old?
That's a very good question, actually. To answer it is to probably give an example of my own dog. Emma will attest to this. I've got a German Shepherd. He's 6 years old now, and he presented tying up a little bit stiff. And when we decided what to do with him, we could go the nutraceutical route because it's from a risk reward scenario, it's going to have very little risk with some reward, so we go that route. But if I can correct his abnormal posture, his abnormal movement patterns with physio, I can stave off the progression of the arthritis that may be grumbling for a lot longer than just starting them on pharmaceuticals. So again, this is why it's so important to have that input from multidisciplinary point of view, because we may say, actually, we don't want to give any drugs at this point, because if this dog is literally showing the first signs, get him into a physiotherapy program, build up the muscles that can help the joints move and protect maybe a little bit of arthritis that's there, correct, the movement pattern, so he walks normally, so he's not forward loading his weight, and so he can move around a lot better. When that fails on its own, maybe we can look at instituting some pain relief. But if he's not painful and he's just showing slight stiffness, we may be more rewarding to go physiotherapy.
Yeah. So I hope that answers your question. So just as a final, I think anyone that has asked more questions, I will go through these later, and hopefully I'll be able to email Jacques anything that we haven't answered, if that's all right with you. And maybe we even have him on again for all the questions.
Yes, of course. Yeah, it's been great.
So I don't know if you would be happy to just give us your top 3 tips for arthritis that you use in your clinics, or what you feel is important for these arthritic dogs?
Okay, weight loss.
Yeah.
Very often they're a little bit portly. A little bit of weight loss goes a long way.
Yeah.
Try and if your dog's been diagnosed with arthritis, try and get good knowledge base. So not just any knowledge base. So don't go Google dog arthritis and get everything. Go to resources like CAM and that are evidence-based, and try and educate yourself, because it'll just make it easier. And then probably from a long-standing point of view, can I say 4?
Yes, of course. So the
third tip would be find a vet that you trust. And that's going to go the journey with you, because together you can work as a team and will ultimately do the best for your dog. And then the 4th one is there's a community of people. So get in touch, get on forums. If you can feel alone when your dog first gets diagnosed. Yeah. So if you can speak to people who are in similar scenarios to you, it just suddenly becomes, it's just not so overcoming, and you can actually feel like you can do this. It's okay.
Yeah, that's a really good one. I know a lot of people will know this already, but we have obviously the Canine Arthritis Management pages and website on Facebook. We also have this brilliant group that Hannah set up called Holly's Army, which is for owners of arthritic dogs. And that's exactly what that is. It's a community where people, especially when they're first diagnosed with arthritis, they have no idea what they're going to do. And they come on, you can ask any question. And there's so many people there, vets and physios and other owners that are going to support you and look out for you and hopefully give you some good information or point you in the right direction. So yeah, please do join that, and anyone that you hear that is struggling, point them in that direction. Well, thank you very much, Jacques. And as I say, if anyone has any more questions, please do keep putting them down, and I will go through them in the next day or 2, and we'll get as many answers as we can for you. So enjoy the rest of your evening, everyone, and we'll see you all soon. Bye.
Thanks very much. Thanks, Nicki.
Bye.
Bye.